Welcome everyone back to another virtual shadowing session. We're glad that you could join us this Thursday evening. Today we have Ananda joining us. She's a PA specialized in dermatology and aesthetics. I know we have a lot of very enthusiastic pre-PA students out there. A lot looking forward to this session, and we're going to be delivering more with PA speakers in the future. Actually, I believe we have at least one remaining for this spring semester on May 4th. We may have a few more on the schedule, but I know for sure May 4th is a date to look forward to if you're looking forward to our PA speakers. Just to get through a few reminders though, especially if y'all are new, at the very end of each of these sessions, we do have a Q&A. So if there are any questions that come up about the specialty, about Ananda's day in the life, work that she doesn't cover, we're going to have those covered during our Q&A. As we go through the session, feel free to type them in the chat and I will read them out at the very end in the order that we receive them. Second thing I wanted to cover is if you'd like to stay tuned with us for more sessions. So if this is one of your first sessions and you're unfamiliar with how we typically post, we have an email listserv and we also have our Instagram page. I'm sure many of you have heard of us through the flyers, whether that's maybe a friend or your advisor that shared with you. But we post those flyers on our Instagram page and also on our listserv. Our listserv is a weekly email listserv. It includes not only our flyers, but a few extra opportunities from time to time. Especially later towards the end of the summer, we're going to be releasing our programs for volunteering and mentorship like we usually do every semester. That's all I wanted to cover. One last thing is if you do want to join our listserv, you can either email us at community@hearts4, and that 4 being a number for health.org, or just go onto our website. At the very bottom, there's a subscription form that you can use. But those are all the reminders. Email us if you have any questions. With that said, Ananda, feel free to take it away.
Great. Thank you so much. As I was introduced, I'm Ananda Fidani, and I'm a certified physician assistant, and I specialize in dermatological and aesthetic practice. So I'm going to tell you a little bit more about what I do. Okay. So first, I want to talk about my journey to becoming a physician assistant. I got my bachelor's of science at UCLA. I majored in microbiology, immunology, molecular genetics, and then I needed to get some PA shadowing. No PAs would take me, so I thought, okay, I'll work for a doctor. So I went to my own dermatologist and I said, listen, please, Dr. Marian, she was really well known, please hire me. I'm really smart. I got a 4.0 GPA. I can learn anything. I know I'm not an MA technically, but please give me a chance. She hired me and I eventually became like the peon and I became eventually the head nurse. So what that meant is I started to call back patients' pathologies, tell them they had skin cancer, counseled them. I assisted with procedures, even though I had no training, I learned on the job. So don't forget to ask what you want. Then I decided I wanted to be more involved. So I became a licensed phlebotomist through UCLA Extension. I began to take blood at the dermatology practice. I began to analyze blood results. For Accutane, we took a lot of blood for acne. So I was that person. So I became more involved. I got a letter from that doctor and some other doctors I had met. And from there, I as well as you can see my timeline, I was also doing a 1-year internship at UCLA, the Care Extender program. It's 4 hours a week. Sometimes I would do 8 hours a week. It wasn't a huge commitment, but I did a 1 year. I also did 1 year at USC, the Department of Emergency Medicine program. I put myself where I wanted to be. I wanted to go to USC PA school. So I put myself around USC PA students and USC PA professors, faculty. So I made sure that my face was familiar. So wherever you want to go, you put yourself in that area, right? So I got an internship at the USC DM program. And then I did apply and I got in my first time applying to USC CAC, the PA primary care program. It's a 3-year program and I graduated. And then right when I graduated, I started working in dermatology at Bella Skin Institute for 10 years. So this is where I used to work. So this was where I used to work with Dr. Anna Guanche. She's the tallest brunette, and then another fellow PA. Worked there for 10 years. I actually trained the other PA, trained all the PAs that came through because I was her first PA. And just a little bit more about what I I have, I call this credentialing. So I completed a fellowship through the Society of Dermatological Physician Assistants. It took about 2 years, although I did it at faster speed, but you have 2 years to complete it. It's 22 modules. You have to read modules, read case studies, and then take a bunch of exams to get your fellowship. I'm a member of all sorts of societies. It's really important to give back to societies that you support and they support you. I am an educator at USC PA school. I have taught some dermatology lectures, and I'm very big in teaching the students clinical skills. So injection safety, surgical excisions, mole excisions. So I literally sit down with them and I tell them, this is how you cut. No, don't do that, do that. And it's really valuable because when I was in PA school, we didn't have such a great training program with the clinical skills. So USC has come so far in that department. And I also, like I said, worked for 10 years for a board certified dermatologist. And then recently, last year, I completed 25 formal trainings and conferences. So I am huge in learning. And so I'm a yes person. I'll talk about that later, but I like to constantly learn and make sure that my skills aren't stale. What I learned 10 years ago has changed immensely. So I'm always making sure that I'm up to par on the latest, greatest trainings that I can. And if they're offered to me, I'm going to say, yes, please. What I mostly do now, it's a whole bunch of cosmetic procedures. I just listed them. So if you screenshot this, you're interested, I just put it all down. It's basically injectables, laser surgery, anything dealing with the skin. I used to in dermatology before I moved into just aesthetics. I did melanoma removals. I did full body skin exams, searching for skin cancer. I did a lot of more medical things. And then after 10 years, I had to make a decision. My practice was moving more towards cosmetic, and I have 3 young kids, and it was just sort of an easier transition for me. And so I went pure cosmetic. So just before I forget, this is my contact info. I'm great at responding through DMs. Face by Fidani is my page. I just started. I didn't have social media for the whole 10 years that I was at Bella Skin Institute. I actually wasn't allowed to. So I just started it, and that's my main page. And New Med Spas is where I work now. It's my email. And I am going to start offering sort of like an aesthetics 101 training course. It's still in the works in case anybody ever wants to know, just like, where do I just put this? Or what do I do here? Not all fancy schmancy, but like the basics just to get your feet wet. So my specialty now, like I said, I focus on cosmetic dermatology and aesthetics. So here I'm pulling up some Botox. I have a laser, and over here I did a little medical. I'm injecting somebody's foot fungus. Really fabulous, right? So that's what I do. But my main focus is in facial balancing, which is a huge thing right now. The reason why I became a physician assistant, well, I had terrible acne when I was 16, and I felt like it really, I suffered, my self-esteem suffered. And so when I naturally started working in dermatology to gain more experience to get into PA school, I knew that I had a passion for helping people and helping boosting their confidence. And so that's why I became an aesthetic provider. I love the wow factor when someone looks in the mirror and they feel better about themselves. I'm addicted to that feeling. I love that. I also think skin cancer prevention is extremely important. I had a family member, actually my husband's family member, pass from melanoma, and it could have been prevented and caught early. And so skin cancer prevention is very important. Skin cancer can kill the young, just like testicular cancer kills the young. People think it's not going to happen to me, but it does. And it happens young and it happens fast. So the need to educate and empower patients is really something that was really important for me. So find your niche, basically. I started to do full facial balancing. And so I'm known as Face by Fidani. I do full facial balancing. I'm aiming my practice to just looking at the entire face from head to, or from forehead to chin, and just looking and being like, okay, you need this for skin, you need this, you need that, blah, 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 teeth, everything. So I just like look at the whole person. And so it's sort of my little niche. So this is just a before and after. I threw some in. This gentleman wanted his folds. Can you see my arrows if I'm pointing? Yeah, he wanted his folds helped out a little bit, and his under eyes. So you can see right here, I put a little port, I put in my cannula, and I put some dermal filler, just magically took all of his lines away. And so that's what I do now. These are some more befores and afters. This mature woman had a lot of wrinkles and she wanted her skin smoother. I helped her with that with some Botox and fillers, just a lip and another lip. I'm known as doing really natural results. Full facial balancing. You can see this patient, she came to me like this, and she recently had her after picture like this on the right side. This was various modalities of treatment, from skin to a little bit of cool sculpting. She had no weight loss. This was all injections and sort of balancing her features, lifting her cheeks, pointing her chin more so she has more of a heart-shaped face than a box. So that's what I do. I specialize in full facial balancing. I also fix imperfections. This lady wouldn't wear shorts ever on vacation or bathing suit. She was so extremely embarrassed. So she has a little dent, and I fixed it. These are just a pair of lips that I did. I'm just kind of showing you my day-to-day. I helped this one with her skin. We do microneedling is another lip. And I have two really interesting cases. So I wanted to see if you guys, can I hear them chime in, or can we do anything like, because I have a little quiz, or I don't know how that works, but.
Yeah, absolutely. There's a bit of a delay. So what we can do is, if you want to ask the question, and then we'll go on a little later into the presentation, we'll circle back after we get some responses in the chat, and I can let you know.
Yeah, and I could just keep going. I don't need responses, but this could just be in your mind. You can just ask yourself this question and tell yourself the answer. So this or that. So this woman presented to me with this rash on her body. This is in dermatology. The rash in the photo appears to be an irritant contact dermatitis, allergic contact dermatitis, a chemical burn, herpes zoster, which is shingles, or a very serious form of lymphoma of the skin called cutaneous T-cell lymphoma, or mycoides fungoides. So this is how the case went. My patient presented to me and she said, I need a steroid cream. And these are a bunch of oils she had been using. 55-year-old female presents to the clinic with an erythematous rash on her left shoulder. The patient demanded she needed steroid cream to help with the burning and the stinging, since she clearly knew that she had burned herself with Deep Blue, which is one of those oils. Past medical history, just like normal health problems, nothing really to report about, and a history of psoriasis. 2 weeks before, the patient had seen a chiropractor for a pulled muscle, and she had been adjusted and was applying heating pad and the oils to help with that area. So obviously she thought that she had burned herself with a Deep Blue. So when I looked at her, I realized that the rash was one side. It was only isolated on her left shoulder. Well, that's where her pain was, right? But I told the patient that it wasn't Deep Blue, but it was actually something else that was causing her rash. And this is where I was going to say, does anybody know what they think it is? But it's okay, we're on a delay. So this is actually a case of shingles. So I took a viral culture. I cultured a vesicle. So when you do a viral culture, you culture just a clear vesicle, because you need that watery discharge on your culture. You send it out. I immediately treated her with Valtrex, which is valcyclovir, that treats shingles, antiviral, 1 gram 3 times a day for 2 weeks. I didn't care about how, when I was getting back the information, I immediately treated her, because the earlier you get the medication on board, the patient does way better. So when the viral culture came back, it did confirm herpes zoster, and she really struggled with pain. I had to also add in some lidocaine patches, and it was unfortunate that she had gone so long with this rash. She presented me like this, but she said, I burned myself with Deep Blue, but in fact, she hadn't. So a little bit about herpes zoster. It's a reactivation of chickenpox. You can only have it if you've had chickenpox primary infection. So if you've been vaccinated for chickenpox, you usually won't get shingles because you don't have the primary. The virus lays in some of your nerves called the basal root ganglion. And then when your immune system drops or some other factors, it reactivates. You get a localized prodrome, and that's basically a deep, achy nerve-like pain. And that's why the patient thought that she had to see a chiropractor to get adjusted, because she had a deep muscular pain. She was rubbing on the Deep Blue, and she didn't realize that that was a prodrome for her shingles. There are complications. One of the most important complications is extreme pain. So the faster you get your Valtrex on board, and sometimes steroids, the better the patient does. Post-herpetic neuralgia, 10 to 15%. That is persistent pain after the herpes zoster and nerve pain. It's a deep aching pain. The most important thing that I, as a derm, watch out for if it's in the head and neck is ophthalmic zoster. So the Hutchinson sign is a little tiny vesicle that appears on the tip of the nose. We can assume that the ophthalmic nerve is involved, and the patient could have blindness. Another thing is the Ramsay-Hunt syndrome, and if it focuses on the facial nerve. So if you reactivation of facial nerve, and I was scared for this patient, she had this whole rash that was wrapped around her ear and in her ear canal a little bit, that's an immediate ENT referral. Sorry, ophthalmic exhaustor is immediate ophtho referral, but at Ramsey Hunt, you refer to an ENT because they can have facial paralysis, ringing in the ears, and hearing loss just from the blisters around. So if she had let it go on any longer, we could have had an unfortunate event. I had a patient on a weekend, just a side note, she texted me, I have this rash on my forehead, it's really stinging. She said, I'm going to Mexico, but I wanted to check in. It was a Saturday. I said, sure. She was going to Mexico on a boat. Sure, go ahead and text me the photo. And I saw, again, didn't cross the midline, some vesicles coming down, a little bit on her eyelid. And I asked her right away, do you have any pain on your nose? She said, it feels a little tender. I said, park your boat, get off with your husband. I know you have this whole trip planned. You need to go to the local ER, have an ophtho consult. It's the weekend. You need to have them put you on Valtrex right away. She had some because she had a history of herpes labialis. She started taking it. When she saw the ophtho follow-up, they said, thank goodness you had started your Valtrex that second that you did, because that saved you from progressing into your ophthalmic. Okay, so really serious. And I thought that was a good thing. So the red herring, the moral of the story, don't let a patient's history lead you astray. Sometimes the patients can be so convincing. She came in, I need a steroid. Oh, I'm fine. You don't need to see me. I just need a steroid. Come in. You touch the patient. You examine the patient always. If they have clothes on, you remove the clothes. You look at the problem. You touch them. You examine them. Careful of red herrings. Patients will be bossy sometimes. I love them all. But sometimes you're like, oh, okay, here you go. I'll call you in a steroid. No, it wasn't a rash from the deep blue oil. It was herpes zoster. So that's just that case. I thought it was interesting. Second case, if we have time, I think we do. Yeah. Second case. So this is not my patient. I have to say, this is not my patient. Okay. So the rash in the photo appears to be allergic contact dermatitis, vascular occlusion, herpes zoster, impetigo, arthropod bite reaction, or from a brown recluse spider, Nicolau syndrome from a previous interlesional Kenalog injection, cortisone injection, or refractory perioral dermatitis. A 33-year-old woman presents to your local urgent care complaining of a rash, or of a pain and discoloration of her left nasal labial fold for 5 days. The redness of the rash seems to be spreading and the color of the skin seems off, kind of blue dusky. You decide to give her a course of antibiotics, Keflex, and send her on her way, right? We like Keflex, Doxy for the skin. So follow up with primary care in 5 days or call back if it worsens. I always say urgent care and ER precautions. If you're not sure, you always write that, meaning if it's the weekends coming up, you're always going to say, go to the urgent care or ER if it gets worse and no one's available. So this patient, I have a rash because I think I got bit by something. It could be a red herring. Patient is now back 4 days later and says the antibiotics are not working. The rash is getting more painful and now there's this weird infection starting and pus. Is it a staph infection? What's going on, right? Being the astute PA you are, you realize that you need to ask more questions. So this is my interaction with the crowd that I know is like, what question do you have to ask next? What would that be? What are you missing? Why is it not getting better with antibiotics? It's just spreading, right? So this is actually a case of a vascular occlusion from recent filler treatment. So in my field, it's a huge risk. You have to know the anatomy and where you're placing cosmetic treatments, especially hyaluronic acid filler, because you can occlude vasculature and it could lead to tissue necrosis. So again, this is not my patient, but I chose this photo because I thought it was a good progression and a good learning tool for my talk. So a vessel that's occluded by dermal filler, the dermal filler goes into the vessel, it could be artery, it could be venous, or it could actually compress too. You get immediate blanching because the blood is blocked off in the tissue. So usually a well-trained practitioner would see that sort of blanch and stop what they're doing and wait and not keep going with the filler. Then eventually, if you let it go untreated, you get levatoreticulosis, which is basically like a modeling look or sort of a lacy skin look. It looks really odd. Slow capillary refill. When you're pressing on it and you look and you're comparing, you see that this is a slow capillary refill and you're going, uh-oh, something's up. Did I compress an artery or did I go intra-arterial? Then it becomes dusky blue or different colors. When you get blister formation, that's telling you your tissue is on the way to tissue necrosis, and you can get sloughing off of the skin, ulceration. The skin can die. So it's really serious. I'm sure, I don't really know the education that I'm talking to, so I'm sure some people have a lot of education in this, maybe some don't, but this is a risk of hyaluronic acid filler or any filler for that sense. So If a vascular occlusion takes place in a high risk area, and those are really the glabella, the nose, where the facial artery crosses in the nasolabial fold, it can actually happen anywhere in the body, but these guys actually can go back into the central retinal artery and then it can blind you. So people don't realize that getting nose filler could actually lead to blindness. So you can't just go to anybody to do these procedures. I personally don't do glabellar filler or nose filler. I chose in my practice that I want to sleep at night, and I think that I have the skills to do it, but I just choose not to. I'd rather a plastic surgeon do that in plastic surgeon's office, and he can take you to the OR if something happens. Okay. Fat is actually the most likely substance to occlude, but all fillers have the potential. So Nicolas syndrome, it's kind of a rare injection site reaction. I had looked this up because it's similar to what can happen. 1920 was first described when this really kind of thick solution of salt was injected. It can go into arterial and cause an emboli, and it can also sort of act like a vessel occlusion. Not quite. You can also have a compression. So there's different ways that cause sort of an event when you're doing filler, injecting anything into the body. So you kind of need to know all the different things that could potentially happen and fish out what is going on. So I love this question. It always comes up. Will I bruise? I can't bruise tomorrow. I'm like, girl or dude, look at this. Okay. So many vessels of the face. You're lucky if you don't bruise. So when we put a needle in, we have to be thinking constantly, am I close to this artery? Where am I going? Am I being in a safe zone? With filler, it's really only safe to be on periosteum because that's avascular, or in the skin. And if you're in the skin, you still don't know if an artery is superficial or not. So if you're diving down, you're just going and shooting filler, you're messing with fire, okay? So if you have vascular occlusion, it's a medical emergency and you have T minus 48 hours to fix it, or else it's pending tissue necrosis. So again, the facial danger zones. When we are taught to put filler in the nasolabial folds right here, well, this is variable. This could be superficial. This could be on bone. This could be a few millimeters up around the nasoala, down at this crease. I mean, this guy is so variable. So you can't just memorize a picture and go, I'm safe going here. So when I'm here, if I'm with needle, I am on bone and I'm aspirating for a very long time, double aspirating, triple aspirating. And then still going in, I'm still going, okay, I'm putting a little bit, aspirating again, a little bit. I do like to use a cannula in this area. I feel like a cannula is safer to administer filler in this area. Facial danger zones, again, glabella, nose, infraorbital region, nasolabial fold, but everywhere, okay? Vessel occlusion, again, glabella, can't hit it over the head any more than I am. Nose, so glabella, there's no collateral blood supply. Studies suggest that this area is the most common site for blindness, where you think some say the nose, but they say the nose is the most common area for necrosis, okay? And the second most common cause of vision loss. So again, if you're looking to have these procedures, or you're thinking you're going to do these procedures, you need special training. And I would only advise you to be trained by a plastic surgeon or have it somewhere done with maybe a plastic surgeon who could take you in the OR if something happens, okay? Tips for safe injecting. I love this quote. The fear of injections is a fear of anatomy. If you don't know your anatomy, really, you should not be injecting. You have to know your anatomy. You have to really learn it. I have studied this book. Can't probably see it. There's facial danger zones. I love this book. It talks all about that. I read this book all the time. Learn the vasculature. If you can't identify the major vessels of the face, you shouldn't be injecting. Know the depths of the vessels, particularly in high-risk areas. It's just my tips for you guys. Tips and tricks, right? Aspirating. There's kind of like a to aspirate or not to aspirate. Some docs are like, no, I don't ever. And some docs or some PAs do and some don't. Aspirating can lead to a false negative. Just because you didn't aspirate anything doesn't mean that you're in the clear. There's still a small chance that you didn't, maybe the filler was too thick and you didn't hold it long enough and you didn't get that positive aspirate, meaning the blood coming back. So you can't just go by that. You have to know the anatomy. You can't go, oh, I went in, I aspirated, it's good to go. Things can still happen. The human body is variable. Also, if you aspirate, you could potentially be drawing a vessel closer with the vacuum. So if you're drawing that closer to the vacuum, you can puncture it then with your aspirate, and then you think you're safe and you go, no bueno. It's also impossible to hold steady. If you're hold steady and you're like this, and then you just move by 1 millimeter, I mean, you could come out of the vessel. So I'm just saying aspirate, but know what's going on. All right. Tips and tricks again. So I like to use cannulas. They are long, they're blunt tipped. So that means that when you go in with a needle, you're very likely to puncture through a vessel. But if you're using a cannula that's blunt tip, you're more of pushing the vessels aside with the path of least of resistance. However, there are studies showing that a 27 gauge is just like a needle, it can puncture through. If you have a cannula and you're forcefully going, you can cannulate an artery. I have done it before. Somebody had really thick tissue. I punctured an artery and I got a positive aspirate in my 22 gauge cannula, and that freaked me out. So you can still puncture. So slow and steady wins the race, very carefully respecting the tissue, but a cannula, especially if you're in high risk areas, it's really important to choose the tools that's going to have the least risk to your patients. Patient safety is most important. Another question is, if you mix your filler with and you thin it down with lidocaine, it maybe could lead to a safer injection, because as the lidocaine swells, you might get a compression, but as it goes down, you have less filler in that area. Although there's controversy about mixing filler too, changes this consistency. Tips and tricks for safe injecting again, examine your patient, right? Every time I go in, I flip the lip, I look for pulsing arteries. Sometimes if you just look at them, you can see where there's a pulse. You're like, I'm not going there, right? Or you're marking it out and you're being really strategic where you're going. Inject very minimal, small volumes, tiny little boluses, tiny little dots, because then guess what? If it did occlude, you didn't push with force and put half a syringe in there, you just put a little bit. So when you use hyaluronidase, which is the enzyme to dissolve filler, only hyaluronic acid filler, if you dissolve that area, you don't have to use so much of it to dissolve so much filler. So you do a little bit, you aspirate, you do a little bit more. Max is 0.2. I never ever do 0.2. That's a fifth of your syringe, basically. Nope. So inject slowly and watch a tissue reaction. Okay. Feel for resistance. If you push and it feels like something just went, there's no resistance. There should be resistance in the tissue. If you're pushing, you might be in a vessel. If you're just pushing, it goes wee, right? So that's not good either. Things to consider before you inject a patient. Has the patient had previous surgical procedures in the area? Why? Scarring could trap an artery or a vessel into an area. So even if you're going with a cannula, the vessel doesn't have that sort of ebb and flow. It can't move out of the area if you're putting a cannula. You might cannulate that artery, and that would not be good. Also, if you put a needle in, it's just basically going through scar tissue. It's almost like that vessel is held in place for you to get it. And also their anatomy could have changed. Vessels could change. Vessels could be rearranged, especially in a rhinoplasty. People who are going to do their nose refinement with filler and on a patient that's had a previous rhinoplasty, that's really dangerous, because now we have those predictable vessels, but they could be rearranged. And remember, that could lead to tissue necrosis. You could lose a nose, right? If you're unsure, just refer to a specialist, right? So I like to only work with hyaluronic acid because I can dissolve it. There are other products that are not able to be dissolved. So I always think patient safety is utmost important, and I practice so I can sleep at night. So screenshot this is a good protocol. This is just how to recognize it, what to do. Topical nitropase will vasodilate. You can give them oral aspirin, they can take it. Warm compresses, don't put any ice on it. You want to get that blood flowing in the area if you believe you have vascular occlusion. Have some colleagues on speed dial. You can FaceTime your colleagues and have them ask. Also, I like to test the capillary refill. I like to test both sides, and I like to videotape it and put it on slow-mo, and you can really see what's happening with the capillary refill. If it's really bad, you can send them to hyperbaric oxygen chamber. You can also give them more vasodilating agents. So, and here's some tips just to conclude that students will overlook. I know I'm jumping off of that case study here, but I just wanted to include some tips that students often overlook. If you're interested in getting in this field, there are some great resources out there. So Palette resources and Patreon memberships of certain injectors that you feel like you like their work and that are known to be safe injectors. You can pay to play. Basically, you pay maybe like $20 a month or something, and you can access their videos and training techniques. Learn the facial anatomy. Number one, step one, don't inject if you don't know anatomy. Apply for jobs that you think you won't get. If you're like, oh man, they need 2 years experience and I only have one, just apply. What if they're looking for someone that they can teach or train? I got in straight out of school into a dermatology job. Although I did have dermatology experience, I wasn't a provider in that. I was just a medical assistant. So if you're looking to get a job, there are entry-level jobs. You just have to go for it. I always say, don't just shun those jobs you think you won't get just because you're not experienced enough. Apply for them. Never stop learning. I went to all those trainings in the last year. I never stopped learning. I always try to add to my toolbox, especially patient safety. I'm reading research articles. There's all this research always coming out, conferences always telling us best practices. So I really pay attention to that. Be a yes person again, yes to all opportunities. If a local drug rep is having a dinner and invites you and your colleagues out, go to those dinners. You're going to make connections. You're going to find support groups. You're going to exchange and swap numbers. You never know when those people are going to be able to help you in your career or help you out of a messy situation you may be in. Maybe you meet somebody who's ENT and you have a Ramsay-Hunt syndrome and she's a PA and you go, hey, if I have a Ramsay-Hunt syndrome, I suspect that. Can I call you and your doc? And then they might be able to get them in sooner. You have to make these connections and say yes to the opportunities that are presented to you. Social media, students, keep it clean and classy, please. A lot of schools will look at your social media, employers. I haven't had social media very long, but I started like a TikTok account. One plastic surgeon I was talking to, he already had looked at my TikTok right before I even had talked to him. So he it's just important. Keep it all classy. Make sure that if your grandpa looked at it, you'd be totally cool with it. Word of mouth and local reputation is more valuable than social media fame. Let me tell you, the people that are the bread and butter of my practice that come see me are my real estate agents, my hair people, my local moms, and they tell their family members. Those family members tell their family members. There's a trust and a community you build around you. Social media is great when you have a lot of followers. It's great for brand partnerships and sort of being recognized. But sometimes the people that come in from social media aren't the clients you want. They could be maybe an influencer that wants to work with you, but they want something free of charge, but they take out 4 hours of your day to film and everything, but then bring in more people that want more free stuff. So you have to think about who are you serving? And so I always make sure that I cater to my base, my bread and butter clients, the clients that have followed me around for 10 years. When I moved from one side, I had a lot of patients that followed me and they're supporting me at my new practice. So it's important to build that base and the community around you and your local reputation, because also somebody might come in for a procedure they saw on social media and they're like, well, why didn't mine turn out like that? Well, everybody's patient dependent. And so sometimes people are looking for a certain outcome and they see it on social media. Or I do see some doctors or PAs or whoever that have photos that the lighting is completely different and it's a little bit of false advertising. So when they come in and the patients don't get their expected outcome, it's sometimes a disaster. So those are just my little tips and tricks to recommend to you guys. But I think that's about it. Oh, that was pretty fast, huh? So I talk really fast too, I think so.
Just took a little while to unmute there. My connection's a bit slow, but first of all, thank you so much, Ananda, for getting this all together. I love the cases. They were really in depth, and we have a lot of students who are really interested in hearing about the specialty. Like I said, a lot of pre-PA students here who love to hear from PA speakers and are especially interested in aesthetics too. Just to start it off with some questions. Our first being, like you mentioned, there's a lot to learn, right? Being a professional now, being a practitioner actually in practice and having trained already, how do you stay motivated to continue learning even after being at that stage of your career?
Good question. I feel like in dermatology, I kept seeing the same 10 conditions over and over and over again. Being a specialist in a field, you kind of see the same things rolling through your door, and you almost in a way can master that field. But the aesthetic industry is exploding. And every avenue that we have, we're getting new and new and new and new and new, and we're having all this new research. So I stay motivated because it's exciting, it's new, it's fresh information, and I'm addicted to that. Oh my gosh, wow, I didn't know that feeling. I love learning. So I stay motivated because I also want to be able to offer all the best procedures to my patients. And if someone is asking me for like an exosome treatment, I don't want to look at them and go, what's that? That makes me sound old and stale. I want to know what's in the now. And so I'm really motivated to stay up on continuing medical education. I do still do continuing dermatological medical education as well as aesthetic. So I do a ton of trainings. I just think that with every training I've done and every conference I've gone to, I've always come out with something new that has helped me in my practice immensely.
Another question is, especially for people who like to get into the field, we know that being a medical assistant is a great way. We've heard of being a scribe. Outside of those options, do you recommend any experiences that would be either particular to better exposure later on as a PA or specifically within the specialty of dermatology? Do you have any recommendations for those kind of experiences?
Yeah, so of course, MA, also front office. I had a lot of students that would start at front office because we had our MAs, just answering phones, just start for wherever they can take you. Once you get your foot in the door and they know that you're interested, then you can merge into back office being an MA. I think for derm, I think working in an ER, because I can't tell you how many times I have learned, I've used my medical background information because I'm a primary care PA that went into dermatology. You know, dermatology is only 5% of PA's medical boards, okay? Only 5% of what we learned. And all that 95%, I really solidified working in an ER and sort of volunteering. I even in derm, I've done some body checks and I've picked up some really crazy things by just the way the skin looked and sent them to the doctor. I had one guy remove his whole entire bowel because he had like a red spot on his body that I picked out. So if you can have any of that, that's going to help you in derm, I think. Like not just to get into derm, but it's going to help you in derm. Just knowing the way the whole body looks and sort of a lot of disease processes are manifested through dermatology. So if you can pick that up in the ER, primary care, internal medicine, I know as an MA, but even a phlebotomist helped me, anything will help. An EMT, all of those things will help. You just need exposure to patient care, especially in emergent situations. I think you see, because that's where you see like the end of the problem. And then you can like go, oh yeah, I remember this one case and somebody had this and they had this derm problem and it was actually this. And so you'll remember those cases.
100%. Very memorable and also great for bedside manner too.
100%. Mm-hmm.
To go along with what you mentioned earlier, you said around 5% of PAs are in dermatology, right? To follow or tag along with that, a student asks, what's the kind of career demand that you see in your position in the specialty? And where do you see the job growth going? What's the expected job growth?
Oh, interesting. Well, I think, don't quote me on this, but I think that somebody told me, a trainer told me that there was like 20 to 30,000 more injectors, aesthetic injectors in the last 2 years or 3 years with the pandemic. Everybody just wanted to go do like fun stuff. And so there's a huge boom, a huge growth in the aesthetic industry. PAs are, I mean, nursing too, nursing and PAs and nurse practitioners. I think that whole field during the pandemic, there's going to be a huge growth. I feel like a lot of people are trying to get into medicine. Projected growth, I don't know what the numbers are, but I think we're just expanding exponentially. I really do. And I feel like we get applications for laser nurses all the time. People are really interested entry level to get into this field for sure. Huge prospects for growth.
100%. I think that we see that, outwardly, right? In the field of aesthetics too. It's definitely on the rise. Another question we have is, and it's specific to aesthetics again, or cosmetics, being in that type of setting, how would you say that patient care and interaction differ from other specialties in terms of, for example, continuity of care, those types of things? How would you say they differ?
What a great question. That's why another reason why I chose dermatology was continuity of care, because again, ER, you're like, okay, bye, and you never see them again, but you might think of your patients. I loved dermatology because I had patients that I treated them for acne when they were, 13. And then I was treating them for their stress acne when they're applying to college at 18 or 17. And then they're in law school, and then they're having children. And so I got to see the growth of these patients. And now they're coming to me for Botox, So I feel like in the aesthetic, you have continuity of care, but sometimes people are fickle and looking for a deal. I'll just say it. But some clients, like a hair person, you go to that hair person for the rest of your life because you like the way they do your haircut. You're going to get those clients sort of coming through, and you're going to take care of those clients. Usually they hook on with you and they're good for life, especially your dermatology patients. Once they feel safe with you and they know that you are looking for your skin cancers and looking at their moles, they're going to feel really safe with you and come back to you and refer their friends and family. So it's a really nice vibe. I forgot there was another part of the question, but it slipped my mind what you had asked the first part of it.
It was just in general about patient care. Continuity of care is part of that, right?
Yeah, for sure. I was going to say something, but I forgot, it slipped my mind, but it'll come back to me.
No worries. Another thing I wanted to ask is, there's a lot of routes to stepping in the doors and providing patient care. Like you could be a nurse practitioner, a PA, you have had nurse anesthetists, physicians, obviously. There's a lot of routes. Did you consider other routes like being a nurse practitioner, etc., outside of being a PA?
Good question. So I went and got my bachelor's degree. And so it seemed like the best choice would be for me to go to PA school. PAs are schooled in the medical model, and we're hooked up to medical doctors. I'm supervised by a medical director. And so PAs are a little bit differently schooled than nurses and nurse practitioners, right? So if you get a bachelor's of nursing, then I think that it would be wise to go get your nurse practitioning license, right? So I feel like if as a PA, my road stops here, people go, well, why don't you just continue and then be a doctor? Well, that's different. I'd have to go back to medical school, or I'd have to start medical school. I didn't go to medical school. I went to a 3-year physician assistant program. In order for me to be an MD, to have to reapply, take an MCAT, and then I would have to go to med school for 4 years, and then residency, and then specialty or fellowship. So the roads are very different. I have not thought about doing anything else. I was always PA. I felt like when I volunteered at the UCLA Care Extender internship and the USC DEM program, I gravitated towards the physician assistants. I thought that I liked their personalities. I felt like they're the ones who educated me. What I really noticed is that when I went in a room, they often were the ones that pulled out a chair and sat down and looked eye to eye with their patients and like really made sure that the patient understand what was going on. They didn't start typing. I just felt like the quality of care was something that I had never seen, and I gravitated towards them. So I always knew that I wanted to be a PA. That's just who I chose, that I fell into that group. But yeah, everybody finds where their group is.
What skills would you say are needed to be successful in your career? Actually, coincidentally, we just had another specialist. He was in dentistry though, so it was definitely a different profession, but he was talking about motor skills, right? I'm sure that might be applicable, probably is applicable in aesthetics, of course.
Yeah.
Say there's anything else?
Yeah. Aesthetics, you have to have an artist's eye and a steady hand. You have to be able to push out 0.01 of a cc syringe of Botox into that little tiny space above the lips for the lip flip. If you put too much, their lip's going to be like Elvis, right? So you got to think about your motor skills and your attention to detail. You have to have immense patience, okay? Because we're probably going to treat a lot of picky patients who are looking for certain outcomes, and they might say, oh, this little thing here. You have to be able to understand it and appreciate it and know that that little thing there means the world to them. And so you need to know how to come up with a plan to treat that, even though it's not that important to you. Another thing that you need to be is a psychologist. I hate to say it, but I have a lot of, people who struggle with body image, and I don't treat those patients. Actually, I kind of do my mental screening. And if somebody's sort of red flagging everywhere that they have this problem, that's a little bit deeper. I have been known to refer them out because I know that those types of BDD patients have high failure rate. They often are not happy with their outcome. and they're often really hard to treat. And it's hard as a physician assistant in aesthetics not to be able to please my patient. And I'm happy with the outcome, but they can't see it. So you have to have really a good patience, a good screening technique, almost like a psychology brain, attention to detail, great motor skills. And I think patience. Patience is really important. You have to be very patient person.
100%, especially when patient outcomes make that much of a difference, right?
Totally.
Coincidentally, the same specialist we had earlier this week, he was talking because he was in cosmetic dentistry too.
Oh, cool.
How he has to sometimes turn away from some patients because of those same issues. So
yeah,
definitely is the case.
It's an ethical thing to do for sure.
It really is. Another thing I wanted to ask is work-life balance. So how would you say that is within the PA profession? We've had quite a few PA speakers. They talk about lateral mobility. They talk about ease of scheduling. Some are part-time too. Some are PRN. Could you add to that insight too?
Sure. So I have 3 young children. I have 5, 8, and 11-year-olds. And I also loved dermatology in that there's really no dermatological emergencies, right? Somebody has a cyst, yeah, we can see you tomorrow, right? If you're an ortho or you're cardiothoracic, somebody could have some sort of valve situation, or oftentimes as a PA, you're going to be the one who's going to round in the hospital. If somebody's having an issue, the doc's like, well, I'm paying you the bucks. I want you to go to the hospital, right? So you're going to probably have you're going to be on call. Okay. So there's no call in dermatology. So I think that as a work-life balance, being a mom of 3, my husband's a firefighter. His schedule is really crazy. I go to work at 10 and I leave at 3:30. And I made my schedule that way so I could pick up my kids. I have great family time. I'm doing very well and I'm having fun at work. So I chose this aesthetic profession for a couple of reasons. That's one of them, to be a good mom, be present. In derm, I think derm helped me in that I'm able to recognize skin conditions like this. And so if I see something, I can still leave at 3:30 and process it at home and take care of things at home. I don't need to sort of stay around and be at the patient all night. I can be like, oh, that's a sign of a redness from a laser. Okay, I sort of feel like my derm years, my decade in derm years allowed me to be so in and out with my aesthetic timing. I don't have to be there all day to, have the patient wait for an hour in a room to make sure that's not a vascular occlusion. I'm sort of like, I got it. I nailed those skills down in my first decade of my career to make those judgment calls. And then, of course, I do what no provider should do, but I do give them my cell phone if I ever suspect anything. I'm like, all right, call me if you have any issues, but I don't recommend that. Yeah. But I'm just that kind of provider. I'll give them my email and I'll say, hey, this looks a little wonky. In all of 11 years, I've only had 1 vascular occlusion, and I actually don't think it was that. I just dissolved anyways because I was worried about the patient. And she's been my patient for years now, but I'm kind of that provider.
That is great to have around. It is definitely, like you said, sometimes a risky move, I can imagine. But our next question is, being that a lot of our listeners are earlier in their career, most being an undergrad at the moment, or maybe in a gap year, what's the most important suggestion or just some advice, some key points of advice that you would have if you were looking back on your career and you were in their shoes? What's the type of advice that you think they can leverage early on?
Get good grades in college because grades matter for grad school. I've had some colleagues that haven't been able to get into their medical programs or their PA schools based on their grades, and they've done everything else like humanly possible. So that's just important. Shadowing is important. I think early in your career, picking a physician as a physician assistant, we're supervised by a medical either a medical doctor, or DO, or plastic surgeon. Your supervising physician that you hook up with in your early years are going to set your whole career up. That matters the most, I think, as a PA. When you're fresh out of school, pick to go somebody who's going to teach you. Consider that like a huge long residency until you're off on your own, maybe. But it's really important to hook up and establish your network and establish the people that you surround yourself with. as those that will support you continuously through your career. As a student trying to get into PA school, volunteering is really important, but make your application, make every single thing on your application make sense. If you're saying that you want to help the medically underserved, then don't have a bunch of hours working at a med spa, or, make it make sense. Maybe have more community service on there. So remember, when your applications are looked at, they're looking at it comprehensively, and everything has to sort of vibe. And so I've seen lots of people not get their outcomes because of things like that. So that's just my recommendations to undergrads for sure.
Is aesthetics the kind of field where you have to be in the general field of dermatology for a few years before you can specialize? Is it that type of specialty?
No, you actually can go straight into aesthetics if you want. If you become a nurse or a PA, you could go straight into aesthetics. But I know that most places don't want to hire someone extremely green, right? Because you can get taught all of these techniques and everything, but it does, the more years that you have, the more complications you've dealt with, or the more adverse events or poor outcomes you've sort of seen before, and how they adjust and become fine. I think experience is really important. So I do think that being in dermatology, working under board certified dermatologists, I learned a tremendous amount of information that set me up to be a great aesthetic provider, because we did aesthetics for 10 years too, but I also did dermatology. So I really formed this great respect for the skin. I know how to skin type someone. I know if someone walks up to me and says, can we do this laser? And I go, nope, it's not for you. We're going to pigment you, or we're going to make you super white and crazy splotchy. I can tell the way a procedure is going to go. And that's because of my background in dermatology. So I think being a dermatology aesthetic provider is the best of both worlds. Some dermatology practices don't do aesthetics at all, and some aesthetic practices don't do dermatology at all. So I feel like I have two sort of careers going on. And even though I've shut the derm and explored more of the aesthetic, I always will have that derm core knowledge. So I think it's a great way to start, is starting in a dermatology office for sure.
100%. Well, let's have some more questions rolling in as we continue, guys.
Okay.
Is there anything else that you'd like to mention for students that we haven't already covered?
I think I can't reiterate it enough. Form your circle. Even in undergrad, I have some friends that became pharmacists. One got a PhD in toxicology, and then also went on and got her law degree. So, and I'm in the practicing field. So I feel like I have friends in dentistry. Connect with all those people that you're meeting along the way, because I reach out to these people all the time. It's important to establish your network as you're learning and as you're moving forward in your career. Collect those people that support you, support them, and be available to them, and participate in Facebook. There's a dermatological physician assistants Facebook page, and we can put our cases up there, and we have a whole bunch of minds chiming in saying, oh, I think it's this, I think it's this. So I've made sure that I've collected people so that we're always sort of sharing information. I think that's really important. I know I've mentioned that a lot. Really important to pick your supervising physician and make sure that they support you. If they don't, leave. Simple as that, because you're going to waste time. Okay. I'm trying to think. Those are my biggies for my career. I think those are the things that help me the most. Know your worth, right? Know your worth. Ask for what you deserve, you think to be paid, and take into consideration travel time. Work close to home, right? If you can pick a job that's maybe a little bit less paid, but it's 15 minutes away from your home, versus that job that's you're oh my gosh, this is amazing, and you're an hour away. That travel time with traffic is taking away from the things that you love or your family. So you have to remember that. My first job was 13 minutes away from my work. Right now I work 7 minutes away from my house. So I've always held these sort of set of standards. Really, it's really important to me and my family. So family's first, right? Jobs come and go. So I think those are some valuable things to also know.
100%. Another thing is being in the field of specifically aesthetics, not necessarily dermatology in general, but specifically aesthetics. Do you find it that it's the case that you would only have certain populations or patient populations in certain areas, so you're basically limited with your practice? Like we know that LA, those types of places are famous for their Instagram pages where they have booming businesses for aesthetics. But I mean, you're not necessarily going to find much in Minnesota or the middle of Iowa.
Yeah.
So, thoughts on
Yeah.
that?
Yeah, that's actually a really good question. So I'll put it this way. People want to look good everywhere. Okay. So it's not just LA. LA, we're famous for it. We have Beverly Hills, we have all the plastic surgeons and everything like that. But like we have some property in Coeur d'Alene, Idaho. And when I walk around there, the people who live there are very well, like they maintain themselves. And so I was kind of doing a little digging and I'm like, who's treating all these people out here? There are aesthetic providers in small town in Coeur d'Alene, small town. There are aesthetic providers everywhere. So it is hard to get that rolling if you don't feel like you have a plethora of patients, but there are patients everywhere. And again, that brings me back to your bread and butter of your practice. That's going to be those connections you make, those moms that you meet when you're dropping your kids off at school, those mom friends, they're going to talk. Oh, you get Botox? Oh, you do Botox? You know how many times I get sidelined at birthday parties? So that's how you grow. It's not just Instagram, but you grow because those people talk to other people. My husband's a firefighter. The firefighter wives see me. There's all these little pockets. You have a medical assistant, right? And maybe her nail person, her lash person, then they talk to people. You have your realtors, you have your hairstylists. So anybody who's in service are going to be a channel of potential patients to you. So again, keep your reputation clean, treat everybody with respect. If they're a celebrity, and I've treated a lot of celebrities, but if they're a celebrity or the girl next door, you're going to treat them with equal respect and have time and listen to all their questions. I had a celebrity come in and I told her we were having a hard time to find a spot. And I told her, I will come in on my day off for you, but I will not move a patient for you. And she said, huh? And I said, because I feel like that's their appointment. So I'd rather come up and put myself out and come in a day off, but I'm not gonna move someone else's because that's not fair to them because I'm treating you both with the same, like you're the same. So yeah, it kind of just, I feel like you can get clients anywhere. It just really depends on how you treat people and your bedside manner. And if you're honest and if you have good outcomes, then the business will flow for sure.
I'm sure there's quite a bit of technology that you use in a field like aesthetics. What does that look like?
Technology wise?
Yeah, technology wise, what is the variety there?
Yeah. Do you mean like lasers? Or
yeah, or the student just technology in general, but if you got lasers.
Yeah, that's an interesting question. So with lasers, I'll put it this way. Botox is neuromodulator. There's Botox, Dysport, and there's all these new brands. It's a neuromodulator. There's fillers, hyaluronic acid. There's 15, 17 different types. They're all hyaluronic acid. There's Morpheus 8. Everybody talks about that. That's radio frequency with microneedling. Well, guess what? There's like 10 more of those different devices. So once we have a device, we rebrand it and we perfect that device, but it's the same technology that we're using usually over and over again. It's either going to be ultrasound technology, like all therapy, ultrasound, where imagine you have these ultrasound waves and you're concentrating, just like you have a magnifying glass, you're concentrating to heat up the tissue, like a little burn. It's sound, energy in the form of sound. We have light, right? IPL. We have radio frequency in the form of heat. So we have electrocautery of thermage. We have Morpheus 8. So we have the same machines and same devices and the same technologies, but they're rebranded over time. And you'll see that as a derm PA, I'm like, oh yeah, that's a great machine. Oh, what is it? Oh, it's the same thing. It's just like new and improved because the technology is different. But it's like the same technology, but sort of there's an update in the software, or maybe the user profiles is slightly different. But one of the most interesting things that I think I saw was there is the Pico 4 laser, which we have at NewMed. This machine can treat, is using sound energy and it's quite new, but it can treat any skin type. So with lasers, you have to be very careful with skin types. I would say 4, 5, and 6, but especially 5 and 6. I mean, I went in IPL, I would be like sweating, IPLing a 5 and a 6 because I would think that I would like damage their skin or they had hyperpigment. Well, Pico is FDA approved for all skin types, 1 through 6. For melasma, it's also FDA approved to treat melasma. So I think that's a really cool technology that's relatively new. But again, it's sound, like all therapy came out 10 years ago and that was sound. But I think that all the technologies are the same, but they're rapidly improving the sort of like the patient downtime or the patient discomfort. That's what I see. But I feel like it's the same technologies over and over again. But injectables are changing. Exosomes and bioregenerative medicine is the most interesting thing, I think, right now.
Yeah, I think we had one speaker actually who spoke about regenerative medicine. It's definitely a new field out there.
For sure.
Yeah, speaking of which, I was just wondering, is it possible that a practitioner could get involved that sort of innovation field with biomedical devices? I know that there's startups out there with having MBAs, et cetera. What about the actual practitioners? Can they get involved?
Yeah, absolutely. As a PA, I feel like there's less opportunities. Usually they'll go for a board certified dermatologist or go for plastic surgeons. But let me tell you, I do know one PA, he stopped practicing and he was in my area and he's hooked up with a biomedical engineering company. He's doing all sorts of consulting with them. It really, again, comes to how long you've been in the field, what connections you've made, and how you've proved yourself and your wealth of knowledge. So like somebody like me, I mean, I go to a ton of continuing medical education conferences and things. So I think I'd be better at that than someone who just injects all day and doesn't stay up to date on their learning. So again, it's not just like a PA can't or can. I think it's really patient or provider dependent. But yeah, I could see that. That's definitely something PAs could do for sure. And I've seen one of them do it already. Yeah.
Steps in feeling.
Yeah.
Our next question is, and you touched on this a little earlier, how you mentioned some people might take advantage of the fact that like being an influencer, they can market for you. They might ask that the services be provided free or discounted. And then the influx of other people asking for the same thing comes on. How do you address that? Like how do you go about your policies or standing firm with when that arises?
That's a good question. So by working where I used to work for 10 years, we used a lot of influencers. We had a lot of celebrities come in. I worked with a celebrity dermatologist. So what we did was we would establish a contract at the base. And we would say, okay, if you're interested in this procedure, we require that you're going to talk about it in this light. And then they would say, okay, I'll do it. But we would always get like a credit card. And so if they didn't, then we would charge them so that they know that there's like a deal going on. And a lot of practices do that. But when they bring their other friends, if we don't want to work with them, then we sort of say like our influencer relationships or partnerships are sort of capped or maxed out at the moment. And then there's like a really gracious way that you could say like we're not looking for that opportunity. But they will bring in more people. But influencers are great because I work with them a lot too, but I do it really organically. Like they're paying for services and they're influencers, but I might not know they're influencers. And then maybe they'll say they're an influencer. That actually happened to me recently. She's like, oh, why don't you check out my YouTube? And she had like over 1 million something views on something. And I went, oh, and she said, maybe we can work something out. But I had already treated her like 4 or 5 times. So we had like a natural relationship that developed. And I wasn't like, oh, she's an influencer, let me get something. And she wasn't looking to get something from me. It sort of naturally formed. And I think those are the best partnerships where they're your real client and they decide they want to talk about something. And then maybe you get them like a discount or something. And so it's mutually beneficial, but it's like an organic relationship. It's not like you hired somebody and then, this and that happened. So I think those are the best relationships.
You also go over a few of the other dermatological subspecialties out there. And if you had to pick one in specific, do you have any idea what that might be?
There's Mohs surgery. So you can work in Mohs surgery, which is like skin cancer removal, right? Skin saving. You can work in just derm. You could work in like a psoriasis clinic. You can work in like a hyperpigmentation clinic, subset of dermatology. Aesthetics is huge. Some places only do injectables, some places only do lasers, right? If I could pick, I would stay in a dermatology office where you're doing skin cancer prevention, skincare, and aesthetics, because I feel like skincare and aesthetics go together. Skincare also branches off of acne, but I also really enjoyed looking for melanoma patients. I've caught a ton of melanomas, and that's sort of like, oh, I'm so glad we found that. Like, I'm just so happy that we like found something that could take my patient out fast. So that's what I would pick. Right now I'm in a med spa and I am still doing dermatology. I'm able to, but I do miss my surgical excision. So if you're a surgical person or you like procedures where you're like fixing, cutting, sewing, and you'll know when you go through your schooling, I like to inject, obviously. But I do like to sew too. I think I miss the surgical aspect. So some places refer all their surgeries out. So if you want to be a surgical PA, you need to see if you're going into derm, you need to see if like they do excisions there, because or else you're just going to just be doing the biopsies and you're just doing a little slice. You're not really actually doing the closures and everything, which a lot of people feel like they get sort of in a zone and they really like that. So I think if I could have it my way, I would do skin, aesthetics, and general dermatology all together. I think that's like the best thing to look for.
You mentioned Mohs surgery, and I actually heard about it just recently. Really briefly, though, I just heard that it was not sure if it's a new type of specialty, but I do know that it has to do with skin cancer and its high success rate. Could you elaborate a little more on what makes it so successful?
Sure. So we didn't do Mohs where I worked, but we referred out to a really talented Mohs surgeon. Mohs surgeons, I look at them as like a dermatologist with more plastic surgery combination. So what that means is if you have a basal cell carcinoma or squamous cell or melanoma of the face, the Mohs surgeon is going to take a slice and pack it, but not close it, and put them in the waiting room. And they're going to have their Mohs, usually a mobile Mohs unit in their office, put all the stains and everything and look at those margins in real time without sending it to like USC to get read by a dermatologist. That Mohs surgeon is going to look at the margins and go, did I get it all or not, in real time? So then they have the Mohs patient come back in the room and they go, nope, we got to do another slice because I still see a positive margin. So they do another slice in real time. But in dermatology, in the office, when I would do like a melanoma removal, I know I have to do a wide local excision, right? So I have to do this huge chunk. I'm not doing a small chunk because it's a face, right? I'm doing like a huge chunk, closing it because I know that I got a really nice margin. I send it to the lab, I get confirmation. But in most surgeons, doing sort of a little slice at a time and confirming that the margins are clear, and then they close it. So it could be a 4, 5, 6 hour day for the patient, but it's a high success rate because the margins are tested in real time, as opposed to sent out and then a dermatologist looks at it and then sends it back like 2 weeks later saying, well, sorry, your margin's positive. So there is something called slow Mohs, which is new. Mohs has been around forever, actually. Slow Mohs is new. And that's sort of like what I just explained, but there's another degree. I don't even know what they do, but I know that some doctors are doing slow Mohs, and that has an even higher success rate than Mohs surgery alone. So that's what that.
Great. No, I actually have he's local to the academic institution that we have, and I met him a couple of times, so it's really interesting to know into it. Earlier on, you talked about in your journey, you talked about going through undergrad and then being an MA, also being in the UCLA Carrick Center program. Can you talk about, I know it's specific to California, but I think we have quite a few West Coast students out there. It might be great to hear what that experience was like for you, how you think it could benefit future PAs too.
Sure. So the Carrick Center program was kind of like my first introduction to medicine in a medical setting. So I was in a hospital and I went through OSHA training, HIPAA training, which was great because I was working in a hospital, but I was really like a candy striper. So I didn't really do anything, but I might bring like a pregnant mom in the nursing, in the maternity ward. I might bring her like extra juice. You know, I was just sort of like the go-between. But it was really amazing because my experiences, as soon as I kind of proved my maturity, meaning I wasn't like gawking at seeing something weird or like fainting or whatever, and I was helpful, I had a couple doctors be like, hey, you want to see a C-section? I'm like, sure. Go in there and they put me on a stool. I'm in the back of the room, just completely in awe of seeing a baby come out, C-section, and I have no degree, right? So by these shadowing opportunities, you can see really incredible things. When I was at USC, same thing. I made connections with people, and I would set up a PA's whole tray of what procedure they're going to do, because I really took notes and I made sure that I was actively listening. So when they had a procedure, I would set it all up. And they're like, who set this up? Oh, Ananda did. Oh, thank you. So they'd say, hey, you want to see something cool? Sure. So one time I got to go downstairs into the morgue with some medical pre-med students, and everybody was space suited up, and I got to participate in watching an autopsy be done on a patient that they didn't have their cause of death determined, and she was homeless, and they needed to determine her cause of death. And I got to actually insert a chest tube and see like pus come out, and turn out she had pneumonia. But I actually got to participate in these things. I had no medical training. I just was at the right place at the right time. So when I say these internships are amazing, it's not just about like, okay, well, what do you do all day for 4 hours? It's like, what else do you get to see? All that wealth of knowledge that you're putting in your brain and downloading is only going to help you in your career.
And we have a wide variety of students out here. I know that there's quite a few gap year students and career changers for sure. And I know that some of them have families of their own. So in going through these stages, I mean, it's a lot of time. It's a lot of investment, especially whether you're, younger or older, it's a lot of time. So with that said, from, any experiences that you've seen with colleagues, et cetera, how would you say it's been to raise a family during your education? What's that process like, and how could people maybe take up any tips that you have?
Well, I got pregnant in PA school, so I graduated with a master's, a PA certification, and a baby. So it was like really hard, but I wasn't the first or the last that did it, because I just made sure that, I didn't put my life plans on hold for my medical education. It just made me work harder. It was hard, but I'm really grateful. And having 2 kids during my career, I was still able to recert and pass my PANRE, which is your recertification exam. I was still able to do my fellowship. I was still able to make the time, usually late at night or early in the morning before the kids wake up. But if you're determined and you want to be better at anything, you can put your mind to it. So if you're the type of person that needs 14 hours of sleep and can't function without that, then it's going to be rough for you. But if you're able to make things a priority, then you can do anything.
Earlier on, I think it's been a few months now, but we did have a residency director on the East Coast as a PA. She was in emergency medicine. I know that you talked about having mentors, and that's a great way to specialize, gain some experience. So within the whole PA profession, are those 2 routes that you can take, either a residency or mentorship? Is that set up like that?
Not usually. That's kind of a new thing. You usually will get your degree and then you hook up with your first job, and that job is almost considered as a residency, but just between all of us, don't take residency pay, get paid as a full-fledged PA, okay? But use that time as your residency. So I followed my doc around for like a year before I did a lot of things, but I also was seeing patients, but I learned so much. So I feel like residencies or mentorships, that's relatively new. There are surgical residencies. There is one dermatology residency, and I can try to find out the name of the doctor who runs that, but I really don't even know that many. But again, I graduated in 2012. So I'm sure things have come along, but I haven't really dove into any of that. I probably should ask my colleagues that are more, just getting out of PE school about that. But I just went straight into a job and I got paid well and I learned along the way. So
Speaking of education, it's really helpful to hear study strategies that people have taken up over the years that they've trained. Um, Making sure that things stick in your head when it comes to test time. It can drain a lot of your time if you choose the wrong method, right? So for you over the years, I'm sure you've adapted your study strategies. What's I know it's personalized, but would you say that there's some options that you found helpful that maybe people can try out, see what works for them?
Yeah, so I think for it's very individual, but a couple things that worked for me was I would record the entire lecture and then I would listen to it because I commuted. When I went to USCPA school, I commuted. I lived in LA. I was born and raised in LA. I commuted, and that was about a 45-minute drive. And then with traffic, it sometimes is 2 hours. So I picked a friend and we take turns driving. We listened back to it. And then I'd stop it and go, Carrie, what did he just say? And she'd be like, oh, yeah, I didn't understand that either. And we look it up and we kind of like pick apart the lecture while we were driving. And so that was really an auditory move. And I can tell you that, like, mnemonic devices or like memorization. I mean, I would tell myself the most insane stories using the terminology. And then I never forgot those stories. And then another thing I would do is I would tell myself, -1, or it's not important. Like erythromycin, I just remember ERY, eerie. And so I wouldn't clog my brain with like the full word because I knew I could pick it out on multiple choice. I would just like remember, okay, it's Erie, Doxy, and Minnow. I wouldn't be like erythromycin, minocycline, like I just uncomplicated things. Or sometimes I would color it. So if I had a whole sheet of different, I'll never forget this, parasites and which drugs treated which parasites and what they did. I just put it all on a piece of paper and I used colors. So I was like very visual and I have a photographic memory. And I was just very like, okay, over here, all the greens, and those are all the doxies, over here, all the min whatevers. And so I had it all visual spatial. So I think the best thing was just listening to the lectures and pausing and saying, did that just make sense to me? And if it didn't, look it up right then, because then you're going to learn it at that moment that you look it up. Discussions with colleagues or discussions with students, those were really good. And I gave myself plenty of time. I didn't cram in PA school because this is like people's lives you're messing with. If you're not learning something and you don't quite get it, then think about if there's a time of emergency and you're drawing on what you remember in PA school and you don't quite get it, you're not going to get it then. So you really need to learn these core things, the core knowledge of being a PA. You're saving people's lives. I do dermatology, and that's 5% again. If you're in the ER, you need to recognize certain conditions and know every little thing about it to pick up those subtle details. And so I think it's important to give yourself plenty of time to study. And if that means less social, that's what's got to be, because you can always be social when you have a nice job and you're taking care of patients. So
Yeah, 2 years and it'll all settle down. Makes sense.
exactly.
Makes sense too why it's quite a few years to be trained, because like you said, patients' lives are at hand.
Yeah, you're responsible. Mm-hmm.
Percent. We'll wrap it up with two more questions. The next one being, in that phase of, I'm sure it's a pretty steep learning curve of graduating from PA school, having that knowledge base and then actually applying it. What are the mistakes that you see with a lot of beginners, and how do you think that they can address those?
Woo, okay. So the one pet peeve I have with beginners is sometimes they don't exactly have a healthy fear of what they're doing. And I think it's important to have a healthy fear of what you're going to do, because if you feel like you've mastered it, I bet you haven't, and you have to work out kinks. So I've seen new PAs where I've trained them where they're like, oh yeah, it was fine. I was good at that in like PA school. And I'm like, it's not PA school. You're not suturing a pig foot. This is tissue. And when you go in, you're like, oh, and then the tissue breaks or the suture pulls out because you didn't realize that you have to respect the tissue. So with any procedure, you need to have a healthy fear of anatomy, a healthy fear of what you're doing, just enough fear to make sure you're being cautious, but not enough fear to be like, oh, what am I doing? But have confidence, but have like a healthy respect for what you're going to do, slow down. So I think that's problematic in the beginning, is that sometimes after you pass your boards and you think you're like, I got this. That's like a drop in the bucket of real world. That's like textbook problems, solutions, diseases, processes. When you're in the real world, someone's jaundice might not look like typical yellow sclera. They might look like a little bit off. Maybe their breath smells a little weird and you're sort of putting it all together. So you have to be very observant, and you can't just be like, I got it in the bag, I'm overly confident. Actually, my team, if we hire someone and they're overly confident, we don't like that, because we know that they're learning, and that we don't like that vibe, because you're sort of like, if you feel like you've mastered everything, that's a dangerous place to be. You need to sort of have a healthy fear of what's next, always learning.
100% overconfidence is definitely a little risky, very dangerous, especially with patient lives at hand. One more question we have, just to wrap it up, about your bedside manner. Do you have any maybe examples or just tips in general that you would say are overlooked when it comes to bedside manner? I'm sure that these could probably apply to beginners too.
Yeah, I do have some very strict things. I do a lot of training and mentoring. I've done it with a lot of pre-PA students that I know. I don't like to, if I'm treating someone, I don't like to cross over them to treat them on the other side of their body. I'd rather walk around the table and treat them on the opposite side of the body. Okay. So what that means is if I'm doing something here, I don't lean across them. I think it's in poor form. I like to always be on the right side of their bed. These are things you're going to learn in PA school. With PAs in general, I like to educate. I will always sit down. I never tower over the patient. Unless I know them and it's a quick, I'm walking in real quick to see something, I will always sit down. I will move their bag off the chair and put it on my lap even, but I will sit down and make sure that I'm at eye level with them. I feel like my bedside manner, I'm often complimented on it. It's because I'm not trying to talk over them. I listen to them actively before I even interject. I don't try to wait till they're done so I can say my thing. I really listen, because the patient will tell you what's up in their history. Sometimes you don't even need to examine them. I would say examine your patient, but sometimes they're going to give you the problem as they're telling you. So if you're listening to their history, you already have the diagnosis in your head, then you examine them and you can figure it out. But I think it's really important not to cross the patient. This is actually a tip. If you have a patient that you're not sure about, or maybe it's a psych patient, always position yourself between the patient and the door. So I always am conscious if it's a new patient, or maybe they say this patient's weird, or, who knows. I'll always, more in the ER, I'll always position myself close to the door rather than on the other side, like a counter, and the patient's between me and the door. So being conscious of your body movements. I try not to click my pen. I try not to jiggle my pen, shake my feet. I try to be really conscious of any distractions. Patients pick up on a lot of body language that you might have. So I think that just really listening to your patient, active listening, repeating back their questions, writing things down for your patient to make sure that key points are not missed in your conversation is really valuable.
Some wonderful tips to wrap up our session. First of all, thank you so much, Ananda, for getting us all together. Let's hear some thank yous in the chat for how she wonderfully answered these questions and also went through these patient cases. Like I said, a lot of pre-PA students were really looking forward to this session. So we're so glad that you're able to join us. I do have some last reminders for students who are joining us. So at the very end of our sessions, if you're not familiar, we do have a quiz, and I've posted that quiz in the chat box. It's also on our virtual shadowing webpage, and it's also on our video description, but probably the easiest way to go about it is our chat box. So that's just a quick Google form. 10 questions is all. And if you have 6 or more of those questions answered and correct, then you'll receive the certificate. That certificate will be sent to the inbox email, or the inbox of the email that you list on the quiz. So just be sure that's one that you're comfortable with. It's one that you use. We do recommend a personal Gmail or Yahoo account. And that quiz will be due next Wednesday, March 29th at 11:59 p.m. Central Standard Time. We're going to be joined by another speaker on Monday, March 27th, again at 7 p.m. Central. That's our usual time. Sometimes we do have some changes with schedule, but more than not, it's definitely going to be 7 p.m. Central, usually Mondays and Thursdays each week. That speaker is going to be Dr. Badia. He is a hand and upper extremity surgeon practicing in Miami, Florida. Very excited to see him. He's a subspecialist in surgery. So, and it's also been a while since we had, I think, a surgical specialty, especially a subspecialty. So it's definitely going to be very interesting to see. Like I said at the beginning, follow us on Instagram if you'd like to catch us for more updates. Join our listserv, and also definitely give Ananda a follow for sure. She has some, I'm sure, great content on her Instagram page. If you want to speak a little more about that, if people want to give you a follow.
Yeah, I love it. I actually have started adding a lot of information that I screenshot or I take a picture at a conference. I think, oh, that's really interesting, and I put that in my highlights. So I do have reels of things that we've learned, but I try to collect a lot of information. So I plan on putting more befores and afters, but a lot of information for my pre-PA students that have reached out to me that follow me. So I will be putting more educational content on there for sure. Thank you.
And thank you so much. We really do appreciate it, Ananda.
It's great to be here. Thanks so much.
All right. Well, hope everyone takes care. Enjoy the rest of your week. Enjoy your weekend, and we'll see you on Monday. All right. Take care.